Senator from Tennessee.
Thank you, Madam President. This morning I received a letter from the United States Ambassador to China, Terry Branstad. He said this, quote, "I'm delighted to inform you that China's Ministry of Public Security announced China will make all forms of fentanyl." Thank you, Madam President. Let me just start over. Today, I received a letter from the United States Ambassador to China, Terry Branstad. Governor Branstad's letter said the following, quote, "I'm delighted to inform you that China's Ministry of Public Security announced China will make all forms of fentanyl a controlled substance effective May 1, 2019. If implemented effectively, this will fulfill the commitment President Xi made to the President at the G20 last December in Buenos Aires. That commitment and this key development are direct results of your visit to Beijing, during which you highlighted China's role in the global opioid crisis. Separately, I've asked my staff to share diplomatic reporting with you that addresses China's action in greater detail." That from Ambassador Terry Branstad, our ambassador to China. Madam President, this is important news. It will save thousands of American lives. President Trump deserves great credit for persuading President Xi at their meeting in Argentina in December to do the one thing that our drug enforcement agents have said to us will reduce the flow of fentanyl into the United States more than any other single thing. And President Xi, the President of China, deserves the thanks of the American people for taking this decision, because our drug enforcement agency is convinced that this decision by China and its senior officials will save thousands of American lives. The reason for this, we were told by our drug enforcement agency personnel in China, is that one way or the other, almost every bit of fentanyl that makes its way into the United States starts in China. Now, these are chemicals that are made there, and they're mixed, and then they come through the mail, they come through Mexico, they come through China, they come many different ways, but they start there. And every time China has made some forms of fentanyl illegal, the flow of fentanyl in the United States has begun to go straight down. Now, what President Trump and President Xi agreed to do on May 1 is to make all forms of fentanyl illegal. This means that if some clever scientist in China says, well, this form of fentanyl is not illegal, so I'll make a different form that is, that clever scientist will be out of business. One thing the Chinese know very well how to do, Madam President, is to police their country. And I would not want to be the Chinese person after May 1 who is in violation of the Chinese law that says all forms of fentanyl are controlled substances and illegal in China. In October, I led a delegation of senior members of the House of Representatives and the Senate to meet with the Chinese senior delegation. One would have thought that all we talked about was trade, because trade was important to all of our states. But at Governor Branstad's insistence, in every meeting we had with senior Chinese officials, we said, fentanyl is our biggest problem, and you can solve our biggest problem more than anybody else in the world. Instead of being our problem, why don't you be our solution? Why don't you let the United States point to China and say, you've helped us solve a problem that is killing thousands of Americans on a regular basis. Well, China has now agreed to do that in December with President Trump. It is now announced that on May 1st, all forms of fentanyl will be controlled and therefore illegal. We should watch and make sure that it's effectively done. But what we should say today is that, Mr. President Trump, we thank you for putting on top of a busy agenda in December fentanyl. And President Xi, we are grateful to you for a decision that we believe will save thousands of American lives. And I might add, it's very helpful to have such an effective ambassador as Terry Branstad in China, because he knew how to focus the attention of many visiting delegations. Our delegation wasn't the only one who carried this message. Senator Portman and others have been there. But this is an example of China responding to an urgent American problem, and we ought to give both our presidents much more than both presidents a pat on the back, much more than a pat on the back for this important step. Madam President, turning to another topic, I often suggest to Tennesseans that we should look at Washington as if it were a split-screen television. For example, on last October, on one screen, you would have seen senators throwing food at each other all month long over the Kavanaugh debate. But in another part of the Capitol, you had 72 senators working together, Democrats, Republicans, 3 different committees from the Senate, 5 from the House, working together to enact what the president called the single most important law to deal with a public health epidemic ever passed, and that was the opioids bill. So while we're arguing, which we know how to do, on issues about the border or issues about the special counsel's report, on the other screen, you'll see a lot of work getting done if you'll take time to look. And that means bipartisan efforts. That means Republicans and Democrats working together. It takes 60 votes to get most things done here. We're 53 to 47, so as I did, I learned to count in the public schools of Tennessee. I need to work with some Democrats to get up to 60. And usually when we find that we do that, we get on up to 70 or 80 or 85 because we can take even the most difficult issues and find our way through them. Today I want to talk about one of those efforts, a bipartisan effort to try to reduce health care costs. Health care and health insurance are often conflated. We often mix them up, both in Congress and in media stories. The president sometimes does that too. So I want to be very clear that what I'm talking about is a bipartisan working effort that health care itself, not just health insurance, is too expensive. Health insurance has gotten a lot of attention lately. The president tweeted earlier this week, quote, "Deductibles in many cases are way over $7,000, making it almost worthless or unusable," he said. I agree. High deductibles tied to high premiums make health care inaccessible to too many Americans. And I know that the president is looking at ways to give Americans more affordable health insurance and to protect patients with pre-existing health conditions, and I look forward to hearing his plan. But the truth is the cost of health insurance will not come down or even grow more slowly unless we lower the cost of health care. You can't have low-cost health insurance when you have high-cost health care. And so my top health care priority this Congress is to enact legislation that will give all Americans an opportunity for health outcomes and health experiences at a lower cost. Democrats and Republicans are working together on that to get a result. That's why Senator Murray, the lead Democrat on the Senate's Health Committee, and I are working with Senator Grassley and Senator Wyden, the senior leaders on the Senate Finance Committee, which shares jurisdiction over health care. We're working together on developing specific bipartisan steps to help deal with the startling fact, which has come by experts who come before our health committee, that up to half of what Americans spend on health care is unnecessary. That's according to Dr. Brent James of the National Academies in testimony before our committee. In order to help do that, last December, in order to help focus on reducing health care costs, after the Senate Health Committee held 5 hearings on reducing the cost of health care, I wrote a letter to the American Enterprise Institute, the Brookings Institution, governors, state insurance commissioners, doctors, patient groups, academic experts, and the public, asking them to submit specific recommendations to Congress to lower health care costs. As of the March 1st deadline for response, we received over 400 recommendations, some as many as 50 pages long, and I want to talk about some of those today. But before I do, it's important to know that the cost of health care, in effect, has become a tax on the budgets of families, employers, the federal government, and state governments. Warren Buffett has called the ballooning costs of health care a, quote, hungry tapeworm on the American economy. Almost every day I hear from Tennesseans concerned that health care is too expensive. For example, Sherry from Hermitage, Tennessee, wrote me about her daughter's family and said, they're new parents. They spend almost as much as health care premiums as they do on their mortgage payments. That doesn't include the out-of-pocket expenses, such as co-pays and deductibles, Sherry said. Many people worry about a surprise billing, which is when a patient receives care at an in-network hospital, but an out-of-network specialist, like an anesthesiologist, for instance, also treats the patient. Todd is a father from Knoxville, Tennessee. He recently took his son to an emergency room after a bicycle accident. The son was treated. Todd paid a $150 copay because the emergency room was, quote, in-network for his health insurance, and they headed home. So Todd was pretty surprised when he received a bill later for $1,800 because even though the emergency room was in-network, the doctor who treated his son was not. I hear a lot about the high cost of prescription drugs. Shirley recently wrote me from Franklin saying, as a 71-year-old senior with arthritis, I rely on Enbrel to keep my systems in check. My copay has just been increased from $95 to $170 every 90 days. At this rate, I'll have to begin limiting my usage in order to balance the monthly budget. I hear from doctors about administrative burden. Dr. Lee Gross, a Florida primary care doctor, testified at one of our hearings that insurance and government regulations were making primary care too expensive. Dr. Gross is one of the first direct primary care practice, he founded one of the first primary care practices. This is where a patient might pay $60 a month for an adult, $25 for the first child, $10 for each child after, and receive all their primary care, strep tests, vaccines, minor surgical procedures, and more. He calls it Netflix for healthcare. After you pay your membership, you don't have to pay for each episode of care. Dr. Atul Gawande, who is leading the Amazon Berkshire Hathaway Morgan healthcare venture, told me recently in a conversation that direct primary care doctors are a powerful group for driving improved outcomes in healthcare because the doctors take responsibility for the outcomes, the risks, and the cost to the patient. I also hear that the place where medical procedures are performed can make healthcare more expensive. For example, Michael from Johnson City shared that he recently had an endoscopy of his esophagus, a fairly common and routine procedure. He had the procedure at an outpatient facility, which typically is less expensive than a hospital. However, the procedure was done as being billed at the hospital. Now, Michael is on Medicare, and he wrote to me saying, quote, not only am I charged a higher hospital rate, but taxpayers are charged a higher rate as well. I imagine that every senator has heard similar stories from people in their states and wants to do something about reducing the cost of health care. In order to the more than 400 comments we received, American Enterprise Institute and Brookings sent us a detailed list of 18 specific policy recommendations. Some of these the Senate Health Committee can work on. Some of these fall under the jurisdiction of other committees, and some are steps that the administration itself can take without congressional action. My staff and I are still reviewing all these, but I wanted to mention some of them today. One reason why health care is so expensive is that the cost is in a black box. Patients just don't know how much a particular test or procedure will cost. That makes it nearly impossible to adequately plan for future health care expenses. And because of that, the health care system does not operate with the discipline and the cost-saving benefit of a real market. Congress has already taken some steps to increase transparency. For example, last Congress, we passed and the President signed legislation by Senator Collins of Maine to ban the so-called gag clauses in pharmacy contracts that prevented pharmacists from telling a patient that a drug is cheaper if you pay with cash instead of your insurance. And now we've received recommendations on how to build on that first step. For example, patients shouldn't be prohibited from knowing the cost of a surgery or doctor's visit in advance of scheduling the procedure or appointment. And insurers and employers should not be prohibited from providing patients with information recommending lower cost options or higher quality providers. Another recommendation, Mr. President, this one from AEI and Brookings, is that employers contribute claims data, which is information on how much a test or service costs and how much insurance is paid for it, to what is known as an all-payer claims database. 18 states currently have these databases, so employers and insurers can see trends in healthcare spending. This would help break open the black box around the claims data for the 181 million Americans who get their health care on the job. One of our new Health Committee members, Senator Braun of Indiana, owns a manufacturing company and a distribution company. He employed over 1,000 people before he became a senator, and he was aggressive about helping his employees reduce health care costs. Healthcare Blue Book, a Tennessee company that testified at one of our 5 hearings on how to reduce health care costs, recommended we look at the clauses in contracts employers sign with insurers that block the employer from accessing de-identified claims data that they could use for purpose of price and quality transparency. The Trump administration is also focused on transparency. For example, Secretary Azar has proposed a regulation to start requiring advertisements for prescription drugs. Make sure they include the list price and ask for feedback on the idea of requiring that the prices patients pay for medical services also be disclosed. Another strategy for achieving better outcomes and better experiences at lower costs is to focus on the 300,000 primary care doctors in our country. Dr. Sapna Kripalani of Vanderbilt testified at one of our healthcare cost hearings that primary care providers are the quarterbacks of healthcare. By coordinating a patient's care, managing their chronic diseases, and providing other preventive care, primary care doctors are able to help patients stay healthy and out of the emergency room. Adam Bowler, who leads the Centers for Medicare and Medicaid Services Innovation, told me that while primary care accounts for only 3 to 7% of healthcare spending, it can affect as much as half of the spending. One recommendation we received from Dr. Gilliam, a primary care doctor in West Tennessee who runs a primary care practice, the same type of practice I mentioned earlier that Dr. Gross runs, was this. Dr. Gilliam said, direct primary care is the only model that's able to offer affordable health care with complete price transparency. One suggestion we have heard is to change Internal Revenue Service rules that block Americans from using their health and savings accounts to pay for the monthly direct primary care fee. And then there's drug pricing. Many recommendations are focused on reducing what we spend on prescription drugs, which is about 17% of all healthcare spending. One way is reforming prescription drug rebates, the discounts that pharmacy benefit managers negotiate with pharmaceutical companies. The Trump administration has proposed a new rule for the $29 billion in rebates on prescription drugs that the government pays for through Medicare Part D. One recommendation is to expand that to the estimated $40 billion of rebates negotiated in the private market. Then another way to lower drug prices is to increase competition through generic drugs, which can be up to 85% less expensive than brand drugs when there are multiple approved generics. I've heard concerns about brand drug companies not providing generic companies the samples needed to make generic drugs and other ways that brands delay drug competition. It was recommended that we increase competition for the generic version of biologic drugs, which are called biosimilars. One way to do that may be a bill Senator Collins introduced last week to ensure that biosimilar manufacturers have access to the information they need to develop and bring to market more biosimilars. And then surprise billing. AEI and Brookings also recommended we focus on helping to eliminate surprise medical billing, which is what happened when Todd of Knoxville took his son to the emergency room. AEI and Brookings said that the issue is not that insurance companies have limited doctors and hospitals in their networks, but that, quote, emergency departments and ancillary physicians, as well as hospitalists and ambulance companies, have a lucrative out-of-network billing arrangement unavailable to other providers, unquote, which encourages doctors to go out of network and send patients high bills. Senator Cassidy, Senator Hassan are leading on a way to help eliminate surprise billing. We received comments about the importance of the seamless exchange of information between electronic health records. That includes stopping information blocking, a goal of the 21st Century Cures Act, a bipartisan bill that Senator McConnell said was the most important bill of the last Congress, was to make it easier for patients to access their health care records and for doctors and hospitals to get the information they need to treat patients. Last month, the Department of Health and Human Services released 2 proposed rules required by the Cures Act to lead better coordinated care and less unnecessary health care. We held a hearing on those last week. We heard a story of the better experiences and outcomes that can happen when healthcare records are interoperable. And finally, consolidation of healthcare. We received comments on the decreasing choices and competition in the healthcare system, which is when hospitals merge with doctors' offices or other hospitals, insurers merge with other insurers, or hospitals and insurers merge, so that these hospitals or insurers have even more control over the market. Some argue that consolidation in healthcare can benefit patients and lower costs. Others say that gives patient fewer options and healthcare prices increase. AEI and Brookings suggested that one way to address the potential negative consequences of consolidation would be improving oversight of the 340B drug discount program, which has been found to incentivize hospitals to purchase physician practices or employ physicians directly to bring in additional revenue from the 340B discounts. This echoes what we heard at our committee hearing. Today, I'm also asking that other senators continue to come forward to Senator Murray, to Senator Wyden, Senator Grassley, and to me with their specific proposals for how we can reduce healthcare costs. What I hope to do is compile the proposals that fall under the jurisdiction of our Senate Health Committee into a package of legislation that the committee will vote on early in the summer. We can then combine that with whatever the Senate Finance Committee passes and ask the leader to put it on the Senate floor and work with the House to send legislation to the President's desk. Secretary Azar this morning, in a hearing before the Appropriations Committee, reiterated his support and the President's support for this bipartisan process to reduce health care costs. My staff and I will continue to review recommendations and work with other members to incorporate ways to give Americans like Sherry, Todd, Shirley, and Michael better outcomes and better experiences at lower costs. Thank the President and yield the floor.